Today, we're talking about a drug where getting it right is, well, it's everything. I'm talking about pediatric epinephrine. It's a lifesaver in emergency medicine, but it follows two totally different playbooks. And getting the right playbook can make all the difference. So let's break it down.
So here's the puzzle, right? You've got one drug, and you even start with the same base dose, but you're using it in two completely different life or death pediatric emergencies, anaphylaxis and cardiac arrest. The protocols are just worlds apart, and knowing those differences cold is absolutely essential.
All right, first up, anaphylaxis. This is that severe, scary allergic reaction where the body's systems are just going haywire. We need to get epinephrine in, and we need to do it fast. And the key here is how we do it, the intramuscular or IM response.
Okay, so here's the number you've got to lock in your brain because both protocols start right here, 0.01 milligrams per kilogram. This is our foundation. We're going to see this number again, so don't forget it.
So the route is intramuscular, but what's really key is the where. Specifically, it's into the anterolateral thigh. Now, why there? Well, it's a big, beefy muscle with a great blood supply, which means the drug gets absorbed super fast and can get to work fighting that allergic reaction right away. And this right here, this is a huge safety check, the maximum single dose. For anaphylaxis, you're going to cap out at 0.3 to 0.5 milligrams. It doesn't matter how big the child is, you do not go over this limit in one shot. Keep this number in your head because it's going to be a big contrast to what we see later.
But what if that first dose isn't enough? Well, you can give it again. The protocol says you can repeat the dose every 5 to 15 minutes. But notice the most important part. If symptoms persist. This isn't about watching the clock. It's about watching your patient and making a clinical call. Okay, total 180 here. We're moving from an allergic reaction to a full-blown cardiac arrest. The heart isn't pumping right or at all. The rules of the game just changed completely. We're not just trying to calm down a reaction anymore. We're trying to restart the heart. Hey, look familiar? It's that same number again. 0.01 milligrams per kilogram. But please do not let this fool you. Because we're in a cardiac arrest situation, the way we use this dose is fundamentally different. The patient has no circulation, and, that changes everything. And here is our first huge fork in the road. In cardiac arrest, an IM injection is pretty much useless. I mean, think about it. If there's no blood flow, sticking a needle in a muscle isn't going to do anything. We need to get that drug directly into the central circulation. That means going intravenous, IV, or intraosseous, IO, right into the bone marrow. And the details get even more critical here. For IV or IO, you have to use the 0.1 milligram per milliliter concentration, what we often call the cardiac concentration. And remember, this is all happening while you're actively doing CPR. It's part of the whole resuscitation dance. So remember that max dose for anaphylaxis? Well, for cardiac arrest, we blow that out of the water. The ceiling here is 1 milligram. That's double, sometimes even triple the anaphylaxis max, which really shows you just how serious this situation is. The timing also makes a big shift. It's not about symptoms anymore. Now it's all about the clock. In a pediatric code, you're pushing this dose every 3 to 5 minutes like clockwork. It's a rhythm timed perfectly with your CPR cycles and rhythm checks. All right, so we've walked down both paths. Now let's bring them together and put them side by side. This is where it all really clicks into place. Just look at this. It lays it all out so clearly. For the route, you've got muscle versus straight into the bloodstream. For the max dose, a smaller safety cap for anaphylaxis versus a much higher, more aggressive dose for cardiac arrest. And frequency, patient-driven versus clock-driven. They are truly different worlds. So after all that, if you're going to remember just one thing from all of this, what should it be? What's that ultimate memory key you can just lock away? This is it. This is your cheat sheet. Peds Epi 0.01 megs per kg IM for anaphylaxis, but you cap it at 0.3 to 0.5. For cardiac arrest, same starting dose, 0.01 megs per kg, but it's IV or IO, and the max dose is a full 1 milligram. All the critical differences right there in one sentence.
So we'll just leave you with this question, because in these high-stress situations, it's not just about knowing a drug. It's about executing the right protocol for the right emergency without a single hesitation. The details really, truly do save lives.